Spiritual Care Conference. Today's is the last of the 4 webinars of this year's conference. People are still signing in. We'll just wait a couple seconds. Our topic today is daring to think about life and death, advanced care planning in COVID-19. The speaker is the Reverend Mr. Shawn. My name is Julian Olivier, chaplain here at Wentworth-Douglass Hospital. My colleagues, Michelle Guest-Lowry, Karen Whitmore, and I will be your hosts. Please note that for this webinar, the chat feature is not being used, but we do welcome your questions using the Q&A button. So if you go to the Q&A button, while things are going on, you can type in your questions and we'll be using those at the end of the presentation. At the end of his life, in the moments prior to fulfilling his sentence of death by poison, Socrates contemplates in deep serenity the relation of truth and death. In the words of his student Plato, the one aim of those who practice philosophy in the proper manner is to practice for death and dying. On December 8th, some years ago, I was on my way back from work. I stopped by my neighborhood hardware store to pick up a storm window I'd left there to be repaired. At 5:30, the store was empty except for the owner, a young employee, and myself. 3 men burst in, guns in hand. 2 wore masks, and they were not Corona-19 virus masks. The head guy had no mask, no disguise on. We were quickly rounded up and tied. Once the safe was opened, and with a gun to my head, one robber asked the boss of the robbers, "What do we do with these blank, blank, blanks?" The answer was both terrifying and sad. Terrifying because of what might ensue, sad because it all seemed so fruitless. Nothing heroic about any of this. "Shoot them if you want," he said. "Just hurry up." My life flashed through my mind. I said goodbye to my wife and children. In the second of these webinars, Debbie Davis quoted Martin Heidegger. In Heidegger's view, it is the encounter with death that most profoundly highlights the question of existence. Over the past 10 months, coronavirus has claimed nearly 240,000 lives in the United States alone. Imagine a scenario where you are lying on your deathbed, reviewing your entire life. How would you evaluate your current existence? Besides reviewing your life, if today you could plan for that deathbed experience, what would you tell your caregivers? What would you tell your family, your nurses, and your doctors? Today's webinar is highly relevant. Daring to think about life and death, advanced care planning in the age of COVID-19. Our speaker is Shawn. Shawn is Vice President for Population Health at Cheshire Medical Center, Dartmouth-Hitchcock in Keene, New Hampshire. His role is to lead community health improvement and clinical interrogation strategies. Shawn is the former executive director of the Foundation for Healthy Communities, where he developed the foundation into a statewide organization to improve health and health care. And that's where Shawn and I first met, because he was the instigator, he was the man behind the forms that we use, and in fact, the New Hampshire law, I believe, dealing with advance directives. Mr. LaFrance currently serves on the boards of the Monadnock Collaborative and NAMI New Hampshire, the National Alliance for the Mentally Ill. In 2017, he received the Bayard and Corbet Leadership Award from the New Hampshire Hospice and Palliative Care Organization. Shawn was ordained a deacon in the Episcopal Church of New Hampshire in 2017, serves a parish also in Concord. Shawn received his BS degree from the University of New Hampshire, and he holds a master's degree in public health and an MS in urban planning from Columbia University. Reverend Mr. LaFrance's presentation will be followed by your questions and discussion. Please use again the Q&A button. Welcome, Shawn LaFrance.
Hi, Julian. Thank you. Thank you for that introduction. Everybody can hear, I presume. The opportunity I really appreciate. And as I was thinking about this, this presentation, I was reminded actually that my first work in terms of doing, really getting into the advanced care planning, and particularly the forms and the reform of the forms, came about because of the bioethics committee at Wentworth-Douglass Hospital. There had been an incident where a person went into the ED and the person had received, he was coding and received resuscitation. And in a follow-up meeting, there was discussion about why did they try to resuscitate him, because he did survive long enough to go up to the ICU and died a couple days later, and the family was upset, and there was a lot of discussion about how it proceeded. The doctor wasn't around, and remember it was in July. Anyhow, that led to a meeting where Douglas brought together the hospital ethics committees over in the Seacoast, and I was invited because I was trying to do some work in this area. And when the managing nurse of the ED said that they resuscitated the man because even though there was some piece of paper, her thing is, we aren't allowed to take orders from doctors who aren't on our medical staff. And I came back to Concord at that point and talked to a colleague who works at the law school and said, can you kind of research that law? And it turned out we had no law. So this was back in 2000. There was no such thing as a DNR law. It was obviously just done by custom in different places. And so that led to creating a whole effort to look at advanced care planning, advanced directives, and make some changes. And that work is ongoing, as I'll reference later on towards the end of this presentation. In any event, if you want to move to the next slide. I'm sorry, I'm not able to advance them, folks. Yes, so you can go to the next one, please.
That was a very good idea, Shawn, but I got to go back and start over. I think that I need to do this way. Let's try again. Right. We had this all worked out, didn't we? Slideshow. Okay, here we go. Sometimes the best laid plans, huh? From the beginning.
Okay, great. Thank you, Julian. So for this presentation, I really thought about three themes. As Julian mentioned at the introduction, obviously advanced care planning involves thinking about death. And, but there's a lot, if you will, maybe new and different given the pandemic. I also wanted to touch upon this, our spiritual being, and also the word I like is daring to think about death, which I'll credit you, Julian, with that in our early conversations about this. And then finally, I will touch upon some current stuff in terms of advanced care planning. Next slide. So we know that this pandemic is unlike anything anyone alive today has experienced, since it's been more than a century since we've had something like this. And sadly, we know in the most current news, yesterday I heard 10 million people with COVID cases to date thus far in the US. And also, more than 236,000 people have died. And then the other number below, about 300,000 excess deaths. When I was looking at the information about this from the CDC, the 236 number refers to the confirmed deaths with COVID. But when they did a review of the of data from January until the 1st of October, they are tracking this large number of other people dying, and they may have not had the test or something, the confirmation of COVID. So clearly it's just having a terrible impact all around our country and affecting the whole world. Next, please. But while the pandemic is something at a global scale we're all experiencing, in reality, we are experiencing it different. And as we know that the age of people who've been dying, most sick and dying from COVID are folks 60, they reported in New Hampshire as 60 and older. The breakdowns are much more precise at the CDC level. And this just snapshot of the age thing is to point out that it has increased in recent months over the summer with adults in the age range of 25 to 44. So again, it does affect everyone, and so it's important, I think, that people understand that it's not solely folks who are older or living in different kinds of long-term care facilities. Next slide. And then the other thing that's been very striking when one looks at the information in terms of people with confirmed cases and how that's transforming through our population, that the increase has been highest among persons Hispanic ethnicity, and also very high, 33% increase among Black African Americans. So we know that the risk factors that relate to this are variable, and certainly certain things like people who are diabetics or has respiratory illness and underlying conditions such as that are at risk. But there are other risk factors like a person's race and ethnicity that is also doing that. The transformation for those of us who work in healthcare and or chaplains who visit healthcare facilities to support people has really changed. And this image just points out how again, we all are masked and actually have face shields and all kinds of equipment that would not normally be how we are reaching out to care for people. Next, please. The power of this, I thought, was striking also because it's been going on for so many months now, and the numbers keep climbing. And there's been some, in the popular culture, I guess, you could say there are some folks who see this as maybe overblown and not so, we need to just get on with our lives and not get so fixated on it. But I was struck because when I saw this, when I looked at the data and realized that, when I think of September 11th as a point of comparison, there were almost 3,000 people that died in the various attacks in the US that particular day. And that was a transformative day, I think, in the lives of many of us who remember it, and how it shaped so much of changes in policy and practices, the whole concept in healthcare, the incident command and things like that we all do and know well. All of that came about because of that, those tragic attacks. And yet, when I look at not only the cumulative, just the number of people dying back in the spring was striking to be so much higher actually than September 11th. And I think this is so new and so evolving that sometimes we forget because it goes over so long a period of time. On the right-hand side, it just shows you that from the CDC, it's hard to read, but really what it's about, it's a projection of hospitalizations in the next 4 weeks. And so there are different models for doing that. I mean, nobody can predict exactly how many new people will be hospitalized. On a positive note, we understand more about the disease now, or the virus, than we did back in the spring. So some of the requirements in terms of hospitalization and death treatments have changed and is positively influencing that. Nonetheless, the estimate in the next month is anywhere from 2,500 to 13,000 people will be hospitalized just in the next 4 weeks. Next, please. So that's a little bit of the numbers. I guess my public health background just makes me want to look at some data sometimes. But the real thing is, what's happening in the lives of all of us. And isolation and loneliness are two of the consistent themes I've heard in talking to people, not only folks caring for people in healthcare facilities, hospitals, and long-term care, but really, I think in many of us know this in our own lives, or I know in the congregation where I belong that people who are isolated, home alone, are feeling loneliness to a degree that is somewhat unprecedented, I think, for many people. We know loneliness prior to the COVID pandemic and the isolation it's brought on is a negative and contributing factor to poor health outcomes. So it's only been exacerbated, I believe, in terms of this pandemic. And as we think about that isolation or that inability to sort of touch or be with people, I think that's relevant when we're thinking about what gives life meaning. One of the questions we ask when we're talking about advanced care planning. But in addition to that isolation and loneliness, the financial stress is enormous. Tens of thousands of people have lost their jobs. They've had cutbacks in their work, their income. And we know that food banks and food pantries, as you can see on the left image, are overwhelmed actually with people lining up and needing support just to keep food on the table and maintain their housing and such. So that stress is added to it all. And then the medical care field, which is obviously to treat and help and restore health and well-being, is also dramatically changed in the image of, nowadays people having their COVID tests done by the drive-through car thing. In Keene this year, we traditionally would do general flu, fall flu vaccine clinics, and they were almost kind of festive things on Saturdays where people would line up and families would come and get their flu shot and stuff. And now that was all switched to, doing it in automobiles and kids separate from adults. And so the ability to even interact with health and medical care systems has dramatically changed in this period where our anxiety about health and such has increased also. Next slide. So back to the point though of what's different or something, I thought this information was fascinating. So this was a national survey done back in April by the Pew Research Center. And the percent of people very concerned that they will get COVID and need to be hospitalized was 24. Basically, 1 in 4 people were very concerned about that. But if you look at the numbers in terms of among Black and Hispanic people or lower income people, you see quite a jump from the 24%. So it's almost 2 out of 5 among Hispanics and 1 out of 3 with Blacks or people with lower incomes. Likewise, there was a question on their survey about who has personally known somebody to have been hospitalized or died. And again, positively, 15% of people said they had, 85 said no. But that number, again, was significantly higher for Blacks, 27%. So again, this is not, there's a lot of disparities, if you will, important variations with the population. So next slide. So plenty of uncertainty and I think, worry, anxiety, and fear are on the minds and in the hearts of people all over, and not sometimes people that would otherwise be thinking like that. I'm mindful of young people I know in their 20s, recent graduates of college or community colleges and stuff, and their intense concern about their futures because looking for your first job at this time in their life and at this time in our world or country is a very challenging process and fraught with anxiety. So with all that changes in those conditions we're living in, it made me think about our spiritual well-being in terms of how are we handling this and how is it affecting us aside from the clinical health stuff of COVID-19. And I just wanted to share, I took this spiritual definition from the assessment book I had in school, a dimension of life that reflects the need to find meaning in existence and in which we respond to the sacred. And the meaning in existence is very much what Julian, what you were saying earlier when you were referencing Debbie's talk. And also I feel like I'm a person who thinks in terms of the soul, and that adding language to how we talk about things like this, the spiritual element and our life force. So all of that is heavily, I'd say, influenced by this pandemic and the huge increase in morbidity and death. And so the stress, the suffering is happening, the relationships that we are accustomed to as individuals in our families, in our communities, in our workplaces. There's an enormous amount of disruption. People having to step out of the workforce. I mean, in our particular hospital, it's been a huge challenge since school resumed in September, and so many frontline people like nurses have children and other technicians that help younger children in school, and their ability to support their family or their kids in terms of learning and still support their family in terms of their work have created significant challenges. Likewise, for people who are religious and or practice a particular faith tradition, the rituals have been disrupted and also dramatically changed. Things are taking place in virtual, on Zoom and programs like this. but the ability to to sing together weekly at some type of a service and to be in the presence of others physically has really changed and created, I think, a significant impact on people's spiritual well-being. Next. And so I threw this little line in question, some questions you might ask from a Mary Oliver poem that I liked. And it's really about, as we think about our own souls and self-care, you know, is the soul solid like an iron, or is it tender and breakable, like the wings of a moth and the beak of an owl? Who has it and who doesn't? I keep looking around me. I like those questions because, you know, the whole process of advanced care planning is asking a lot of significant questions. But I also think in this time, we're really questioning so much about our own being and our own wellness and how we're holding up, if you will. The concept of self-care, I think, is really important for people working as chaplains and/or people in the healthcare field. Anybody caring for others. Next, please. And again, it's just a few things I was thinking about. So I also like this this reference from Teilhard de Chardin about we're not having humans having a spiritual experience. We are spiritual beings having a human experience, and that human experience right now is really difficult, and difficult in different ways for different people. But something we have to be cognizant of, I think, in terms of all the folks that we interact with. Next, please. So a couple of things that I was referencing here is from the Handbook for Mortals. And these are the 4 R's, they say, for the spirit. And when somebody is with somebody who may be contemplating the end of their life, their mortality or something, there's really, these 4 R's are about, you know, remembering things, reassessing one's whole life, reconciling oneself, forgiving oneself, if you will, and then reuniting with people to be at peace. And when I think about those 4 tasks or 4 opportunities to pursue, actually, when people are thinking about their mortality, it's really been a very different environment for people to be able to do that. I know that the people who have been visiting people up on the floors in our hospital are talking about this disconnect and this inability, in part because the restrictions on visitation that happened in the spring and have continued and actually are, I think, going to increase again, so that people are alone, sometimes at their most vulnerable times, without physically having the people they love at their bedside. And then also, I mean, some of these things about reassessing life, I think, is happening because people are maybe questioning now if their career or what they've been pursuing is the path they want to take. I mean, there's significant amount of relocation going on because of the virtual work world, and people, at least in our region here in northern New England, a notable migration, if you will, from more urban areas to the south. You know, our spirits are restless, if you will, because of this pandemic, and the questions that some people might not ever think about or ponder are touching many of us of younger ages and due to the pandemic. Next, please. So the word daring I called out at the beginning because Julian was very helpful in thinking about the presentation and just the concept of thinking about death at this time. And I believe it does take, you know, daring is really about taking risk and being courageous in certain ways. And how each individual responds to that is highly variable, for certain. I think in some ways that the pandemic has created this space for people to think about their choices. I mean, the question around use of ventilators, which became so widespread during this pandemic, that's a piece of technology that I think many people may not have even been familiar with unless they had worked in healthcare or known someone who needed that ventilator. But now that type of thing has been in the forefront of many people who have been sick with COVID and thinking about it. The other side of this, though, is that I think I've also heard the experience of people who are not, who have been affected by this and so significantly that they wouldn't want to think about it now because they're still grieving the loss of a loved one and or their own recovery from COVID, which is, again, highly variable for people. Some people are asymptomatic. Other people for months can go on with some symptoms that continue. And the science isn't all clear, obviously, on this virus and why that happens. But in any event, that, you know, we really all have to, again, think about nourishing ourselves and our families, the patients, and also our colleagues and caregivers. I think all of you who may work in the healthcare setting who have met with and talked with colleagues who are in the ICU or sometimes in other spaces where they are seeing enormous suffering, and, you know, the onset of this pandemic has changed certainly the environment and patients that they've traditionally been caring for. So we move at this moment. I just want to shift over, though, to the concept of advanced care planning. And again, this is the guide that the current one, I think, in publication, used statewide in New Hampshire from the Foundation for Healthy Communities. And it was a booklet that was developed quite a few years ago now, more than probably about 15 years ago when we did the first version of this. And it was intended to make this process of thinking about your plans, being clear about them, and making it less about machines and what machine you want or don't want, and much more about relationships and conversations, which the images on the cover of this were intentionally selected for that reason. Next slide, please. The next one, please. So, you know, why to do this? I mean, it's important because we want people to participate in their care, make their voice known, and also it's an enormous gift that people can provide to their loved ones, the caregivers and such, who are taking care of them when they're unable to communicate or have the capacity to make those kinds of choices. And it matters a lot because the dimensions that one explores in terms of advanced care planning are about values, relationships, spirituality, as well as the medical piece and the making specific plans if they know the trajectory of their illness, their chronic disease. This is harder, much harder now. One of the places where in the hospital where I work, where this has been very challenging, is in the infusion. So the cancer patients who come in for their treatments, because their immune systems are compromised and putting them at more risk, and then having the pandemic in addition to this, these kinds of questions and ideas about advanced care planning and their trajectory in terms of their life and death is been very significant and required a lot of spiritual support. Next. So I thought there's not too much data nowadays in terms of the influence of the pandemic in terms of advanced care planning. It's always an effort to get those numbers up, to get more people to do this. The usual age is, the pivot age is around 55 when people start to think about this and pay more attention. But this was one one brief study I saw online, and it's from University of Pennsylvania, their website, where at their Penn Medicine complex, they promoted advanced directives and such through this web portal. And before the COVID situation, the median number of new ones were 26 per month. And in the pandemic period, that has jumped up to 133 new users per month who are going to that resource. So in that case, I think the awareness and the reality of what this is, COVID-19 is in our lives in the world today is motivating people to think about it and act upon it if this is an indication. We've also seen at the hospital where I work, we have an ongoing effort to people to help them, encourage them to have advanced care plans and to share them with us. So that's part of their medical record when the information is actually needed. And we've seen, except for the spring months when everything was shut down, the numbers are going up again. Next slide, please. So the chart over on the right-hand side is just a chart. Well, it's at admission and in the medical record for our hospital, where the presence of an advanced directive is there. And as noted in the medical record, it's usually less likely to be found than people to say they actually have one when they enter a hospital. New Hampshire has done for the last 5 years, all 26 hospitals have participated in an annual spot survey to identify this, to keep a spotlight on it. And well, unfortunately, it's always been done in February and March, and it didn't happen this year because of COVID. But nonetheless, you know, it's really important work that we not neglect supporting people and thinking about advanced care planning. In fact, and I love this quote from a physician at University of California, San Francisco, that, you know, we're experts on ourselves and our lives. We're experts about what brings meaning and quality of life. So the technology and all that clinical stuff certainly matters and it influences our medical treatment. But we have in our own power and domain this ability to think about what gives meaning and quality to our lives. Next, please. But again, that also is different among the populations we may serve. So the Conversation Project at the Institute for Healthcare Improvement has been doing a lot of work during the COVID pandemic and provides resources. And one of their staff, this is a quote from actually one of their staff members, a Black woman, and her reality, if you will, about the disparities in terms of life and death with white counterparts, and that sense that it may not be such a distant future thing, but it can be much more real for people, different people within our population, and why the issues of equity are so important at this time. And next, just to be hopeful, you know, we are looking forward to a new year, and hopefully the many efforts that are working round the clock for months now in terms of some type of vaccine will bear fruit, and that will become available, and the ability to move back to some sense of normalcy that we recall at the beginning of this calendar year and years prior will be able to happen. Just the next slide. And so that really, it would be the joy, if you will, that we can all interact and you know, touch and be together in close proximity without our masks, and without necessarily having to do everything remotely through technology, that we can still touch a patient and or touch one another in terms of our own lives. And last slide is just this importance of caring for oneself and each other. And also, I've been just reading a lot of stuff for this. And I really thought the quote from this woman from Harvard Divinity School was thought-provoking, that the pandemic inequality has been magnified by the sheer number of deaths across the country. And we saw some of those numbers a few minutes ago. For many of us, it's too painful to turn away. We can use this time to be fully present and ask ourselves, what is my work in the world? And I really think about that, I guess, probably in terms of a person who's done public health most of his career, and then also now serving in a clergy role with a congregation, is that we take care of ourselves and our loved ones and our patients and such, but we also have to really think about it in a much broader context, because I think this pandemic has made us aware in new ways about how life is all connected, and connected globally, in fact, and that we need to think at that scale sometimes in terms of how we want to be and how we want to go forward with our lives. The first speaker, Tom, of this series talked about, I gave this great talk, if you were able to hear it, from a science perspective a lot, but he talked about the concept, or the whole birth, life, and death cycle, which is, from the molecular level to us as humans and many other living things. And I think we all are really looking forward to birth and life as the focus, and have some balance back there. And while death is inevitable and is a part of it, of our life, that we will be able to restore our balance in this area. So that's my closing thought. And but I'd welcome if anybody has any comments or questions about how is this happening in your life today, I guess.
Yeah, well, Shawn, thank you very much, first of all, for sharing the background, the history, sharing your knowledge of all of this, and your insights. So we have this appearance on screen, more magic. There are Michelle and Karen, and they're going to lead us in the Q&A conversation session. Ladies, are you ready?
Yes, and Shawn, thank you so much for that presentation. I really appreciate it. And we do have a first question that's come in, and it's a question, how is it possible to get a copy of the New Hampshire Advanced Care Planning Guide that you lifted up?
Oh, sure. It's available for free online, and the website is www.healthynh.com, and you can find it there and download it if you like. It's also most hospitals in New Hampshire, and I know many hospice VNA agencies keep copies of these around, because they're a resource, obviously, when they're talking to patients who might want to do it.
Shawn, one of the advanced care planning tools I've used in other states is 5 Wishes, which is legally recognized in 42 states. And it's been called the first living will with a heart and soul. I'm wondering why it's not used in New Hampshire, and what obstacles there are to having it recognized in the state.
Well, it's been a challenge, but we've made a lot of progress in that area. And if people do have a 5 Wishes document, I would, and that's all they have, I would certainly recommend and encourage them to bring that with them if they're going into a medical care setting and might need it. We've had, as I said, in the early 2000s, we identified a lot of problems, if you will, with the law in New Hampshire. And in fact, in 2002, we went to the state, because this is all governed by state law, the legislature and such. We went to the legislature, and they created a special committee to study. At the time, we had a living will law and a durable power of attorney for healthcare law. They were actually separate in the statute, and they didn't even necessarily agree with one another. You know, living wills came into being before power of attorney for healthcare. And so that sometimes, certainly for older people like me, you think of living will before maybe power of attorney for healthcare. Anyhow, we were in 2002, the study committee came up with a list of recommendations of changes that needed to be made in New Hampshire's law that would make things like 5 wishes and other forms of documentation more usable or accessible, if you will, in our own state. And I don't know if this is good or bad. It was my lifelong civics lesson that it wasn't until January of 2015 that the recommendations that we had in that report in 2002, in November of 2002, all became implemented in law. That's how many years it took of going back to the legislature and policymakers and people like that to get these changes. So I opened by mentioning that DNR issue that popped up a long time ago at Wentworth-Douglass. You know, that was something we were able to fix. And the last thing that we were able to do that became law in 2015 was the ability to have a surrogate. So when people lack having a designated person for them, there is now in the New Hampshire law default process in terms of surrogate. And so, you know, it's a long process, and it's fraught with lots of social, political kinds of issues. But I can say, actually, there was a meeting this morning. In fact, I was on it. We are a group of us through the state coalition that the foundation still convenes. The Foundation for Healthy Community brings the Healthcare Decisions Coalition together. Several people, we've been working for 6 months or more now about what changes are needed to the law, because even though it's been 5+ years since we went through the legislature with anything about this, we know there are improvements to be made. And probably the one that was most relevant or compelling in terms of the COVID pandemic is that there's a restriction, if you will, in the law currently about the ability of somebody who's a surrogate or a surrogate to or not, and a power of attorney for healthcare, to let a person who they're activated as that decision maker, let that patient participate in any kind of experimental treatment. And as we know, with the COVID pandemic being a new virus where it's been evolving since spring about how to treat it and what types of treatments have been explored, that's been a barrier, if you will, that our law does not give authority to somebody to do that. So that's been that's an example of how the advanced directive policies, if you will, law are frequently undergoing review, and people are working on making improvements to make this easier and more accessible to people. It's kind of a long answer, but I thought it was relevant to the pandemic we're in, that barrier has existed this year.
Thank you, thank you. There is another question that's come in, Shawn. Once the pandemic is under control, what changes do you see from our lives before that pandemic appeared?
Well, I think that probably at a very basic level, the public awareness of pandemic, virus, this all all the kind of risk associated with this stuff is at a level sort of unprecedented in many of our lifetimes. And that and also it's just one more example also of how, you know, the world has shrunk, or, you know, we live on this earth, and things can change rapid, you know, people on a plane can go from one continent to another, and dramatically, something as small as a virus that we've never encountered or understood can hop along for free, if you will, and cause great harm or change. I mean, so it's not, I mean, I don't want to make it sound like it's all negative, but I do think that maybe, you know, I'll say, you know, I sort of took things for granted or didn't think about certain things. And this whole pandemic, not only in terms of the science and the virus and the medical care, is causing this other reflection, if you will, self-reflection in terms of people's relationships and careers. I mean, one of the challenging things that then for people that are doing, when I want to do an advanced care plan, you know, one of the questions we often speak with people about is, you know, what gives meaning in your life, and that sort. And so for a lot of people, that is their family, their relationships, you know, playing with their grandchild, visiting their kids, or traveling to do something, because families are so spread out, but, you know, maybe once or twice a year we all come together and stuff. So this is really forcing people to think about that, and not necessarily change it, but just recognize that maybe the fragility of even that, and or some new ways. I mean, people have found means of technology to stay in closer contact because of the pandemic, and that's a great thing for people. But also, I want to go back to the equity issue, because for those of us in healthcare or public health, I guess, we've known about health disparities in terms of the poor and people with chronic disease and other you know, racial ethnic minorities. And I think it's put a big spotlight on that. And hopefully going forward, there'll be some serious efforts to address it.
Thank you. And here's a very pertinent question. How can we keep up with changes in the AD law?
You know, I guess the thing I would say is it doesn't change too often. You know, we made this effort, I guess it was we did the legislature in 2013. The changes took effect in the 1st of 2015. We're talking now about another potential change, which if it were to pass, or any change were to happen, it would not be until, you know, probably next year. It wouldn't, you know, if they made some changes in May, this coming spring, it wouldn't take effect before January of 2022. So whenever there have been changes, at least in the last couple decades, there's really been a pretty significant effort statewide in terms of education. The coalition that was formed in 1999 around this, again, continues to this day. And I'm grateful that we've had new people, some of us who've been around doing this for a long time, but we've had new people, new ideas and stuff join in. And always the education part of it, public awareness education, is I think we deeply feel is a responsibility to do that. And usually through healthcare provider, you know, health systems, through legal, you know, the people, lawyers who to estate planning and things like that. We have a pretty broad reach when we make a change.
Shawn, there was a reference in your slides to advanced care planning online. Is that a good idea?
in our state, it's not been something that I think those of us who work in this area have advocated that much or done a lot about, in part because the how do you say it, interoperability of different systems to know, you could do something online, but then you're at this doctor's office or you're in this hospital or long-term care facility. That technology, it exists, but it's not easy to move from one platform to the other. I think in some other states though, I know New York State, California, that was Pennsylvania, the one I cited, there have been efforts to create like online registries of this sort. In fact, there was a law passed in New Hampshire to do that several years ago. Nothing ever came of it. I mean, just to, be real in New Hampshire is like, we are now talking about the vaccine, the hope for vaccine that we'll have soon for COVID-19. And we are the only or possibly one other state that doesn't have, we don't even have an immunization registry for like immunizations that kids get and stuff like that. So the infrastructure in our state is not highly developed for that kind of online registry. We can obviously share things online nowadays, and that's good. And, in the case of the example I provided, I mean, Penn Medicine is in a huge medical complex in Philadelphia area. And so that was something they have developed for themselves with the people they care for. I'm not so familiar that any of them in our state, any of the hospitals or the systems are doing that. I mean, they're working within their electronic health record systems to do things like this, and we've seen improvements. That chart I showed a little bit ago about the annual survey we do in New Hampshire hospitals, we found that when hospitals converted into a single new electronic health record system, that the ability to access an advanced care plan or directive when the person's actually in the hospital has significantly improved, because even when you brought it to the doctor's office, if it was sitting in a file in your primary care office, it wasn't available necessarily on the floor in the hospital. And so in that instance, these kinds of advanced care plans and directives are benefiting from the technology.
If you're in hospital or if you're at Wentworth-Douglass anyways, our social workers are available to help with that. We're nearing the end of our time.
Yeah.
Michelle, Karen, any further questions or thoughts?
There is one final question about keeping up with changes in the advanced directive laws. And as you say, this sounds like a moving target in the state. How can we keep up?
Well, like I said, if there were to be a change in the law, there's a group, a statewide coalition convened through the Foundation for Healthy Communities that has actually led these efforts and changes in the law since the early 2000s. And when they are, if someone just from anywhere were to propose something, they would be looking at whatever the proposal is. And that takes a long time to get the change through. And there's always a plan, a public education awareness campaign plan that goes along with it. And like I said, it came up this morning. I mean, one of the things that we've been working on some minor changes to it, if you will, for this coming session of the legislature. And we realized that even though we haven't even got the bill introduced, and it's not even clear yet who's going to be the majority in the Senate and leadership, we were discussing exactly how we're going to alter the training and education that's available to both people that help people do these as well as the general public.
So this has been the final presentation, the final webinar in this year's Spiritual Care Conference. So we thank you, Shawn. We thank all of you out there in cyberspace for your participation today and in the previous events. We also want to thank the many behind the scenes people who have been responsible for the many aspects of this very unique spiritual care conference. In particular, two people, kudos go to Marcus Day of the Education and Professional Development Department and Linda Spaniels of Community Relations, who is lurking there behind. I can see a picture on the screen, but none of you have seen her, and she has been our moral and technical support.
Yeah.
We will appreciate your feedback by completing the online evaluation you will receive. Certificates of participation are issued by the Wentworth-Douglass Hospital Education and Professional Development Department. Certificates will be sent by email upon receipt of your evaluation. So these 4 seminars, we've been asked this question, have been recorded, and the videos will be available to everyone. Go to WD Hospital, so the hospital website, wdhospital.org, and find the spiritual care web page. So that's it. Thank you very much, Shawn, Michelle, Karen, and all of you out there, and do be safe.
Thank you very much. Bye.